In this lecture, we are going to cover the highlights of pregnancy and childbirth. So most people know that we measure pregnancy in trimesters, or three equal time periods throughout the pregnancy. During the first trimester, which is month 1 through 3, or the first 12 weeks, however you want to count, this coincides with the pre-embryonic stage of development and the embryonic stage of development that we've previously discussed. And we have also started the fetal developmental stage that we have previously discussed. During this time, as we complete organogenesis, by week 12, all of the organ systems have started to develop. They are by no means finished. They are by no means fully functional, but we have started the developmental process of all the organ systems by this point. Now, unfortunately, this time period is also the most common time period for spontaneous abortions to happen. These are also known as miscarriages. These are usually due to chromosomal abnormalities that prevent organs from developing properly. So if the body can tell that organs aren't going to develop properly and the fetus would not be viable, the body will spontaneously terminate the pregnancy. It's not the only time that happens, but the first trimester is the most common time for that to occur. Now, common symptoms for pregnant mothers. Of course, every person is different, but just some of the classic or common symptoms include morning sickness, which is not a very good name because it doesn't always happen just during the morning. It could happen at any time of the day or night, but a lot of women will experience nausea and or vomiting. Some people become very, very fatigued and tired. Breast tenderness occurs in many people as the breasts start to grow again. And then some people even experienced increased energy levels. So a wide variety of possible symptoms. As we move into the second trimester, months 4 through 6, the fetus continues to grow and develop. At this point, the fetus has gotten big enough that when they kick, it can now be felt by the mother. The fetus had already started to move around before the second trimester, but it just wasn't really big enough for the mother to be able to feel it, but now they can. Symptoms now for the mother include the morning sickness usually subsides starting in the second trimester, not always, but usually. Energy levels usually pick back up, and the abdominal region begins to expand as the fetus continues to grow. And then we move into the third trimester, months 7 through 9. Now we see rapid growth and development of the fetus, including weight gain. The uterus continues to enlarge as the fetus continues to grow, so the abdominal region continues to expand. Symptoms for the mother now include oftentimes back pain, which can coincide with lordosis. Lordosis, if you remember, is the over-exaggeration of the lumbar curvature of the spine. And so as the belly gets bigger in the front, the lumbar region of the spine gets pulled forward. And so a lot of pregnant women will see a really exaggerated curve in this area. So that's kind of lordosis. The mother's organs also have a lot of pressure being placed on them as the uterus and the fetus continue to expand. Those organs get displaced. All that extra pressure can lead to increased urges to urinate. It can lead to increased heartburn and just a general feeling of uncomfortableness, especially when the fetus starts to move down to the lower abdominal region as everybody prepares for childbirth. Now let's cover a couple hormones that experience a lot of changes during pregnancy. First is human chorionic gonadotropin, or HCG. A lot of people know this from pregnancy tests. Okay, so this is what a pregnancy test is actually testing for. So the HCG, why do we need this? It helps us maintain the corpus luteum. If you remember back to our discussion on the female reproductive system, the corpus luteum is the degraded ovarian follicle. The follicle started to degrade once ovulation occurred. So the little developing egg, it popped out. The follicle that was left behind starts to degrade and starts to secrete estrogen and progesterone. We need that estrogen and progesterone secretion to continue so we can actually maintain the pregnancy. And that's where HCG comes in. HCG is like, go corpus luteum, go, keep secreting those hormones. Now, by the time we hit the 4th month, okay, approximately the 4th month, secretion of HCG has declined because the placenta has started to take over secretion of the estrogen and the progesterone instead. Okay, so we still need those hormones, we still need the estrogen and progesterone, but now it's just coming from a different place. And so we don't really need the HCG anymore. Now, progesterone, again, in conjunction with relaxin, these are, again, coming from the corpus luteum to start with. These are going to prevent uterine contractions until the fetus is ready for birth. So especially early on in the pregnancy, we don't want uterine contractions. Like, we've barely got started in this pregnancy process. We're just starting to develop the fetus. We need to keep it in the oven a little bit longer. That bun isn't done growing yet, as they say. So we are going to inhibit uterine contractions, first of all, during the early stages. Now, later on, when it is time for birth, obviously, we need those uterine contractions. But for right now, we're not ready. Relaxin also helps relax the connective tissues that we find in and around the pelvic joints. This is going to help make it easier for the child or the fetus to actually move through the pelvic inlet and the birth canal during childbirth. And then we have aldosterone. You are probably an expert on aldosterone by now, but just in case, if you have forgotten, don't forget aldosterone helps retain fluids. So it helps increase blood volume. Okay. The extra blood volume can be one of the things that leads to edema beginning in like the later 2nd, early 3rd trimester stages. Then we also have parathyroid hormone. You may not have heard of this one in quite a while, but don't forget this one helps maintain higher levels of blood calcium. So if you remember our discussion on fetal development, ossification begins around the 3-month mark for the fetus, and we're going to need a lot of calcium to make that happen. So parathyroid helps make sure that the blood of the mother has enough calcium in it that she can then pass on to the fetus for proper bone development. Okay. Now, prolactin stimulates milk production in mammary glands. That one's pretty well named, and that one's pretty straightforward. Then we have oxytocin. So oxytocin has 2 different jobs. Job number 1 is to actually stimulate uterine contractions. And so we don't really start releasing oxytocin until the 2nd, the 3rd trimesters, and peak secretion of oxytocin occurs during actual child birth, the labor and delivery part, because now it is time to expel the fetus from the uterus. So we need those contractions. In addition to the uterine contractions, oxytocin, I said, has a second job. So its second job is to allow for milk release from the breast. Sometimes you'll hear that referred to as milk let down. And so prolactin helps make the milk, but oxytocin lets us actually expel the milk from the breast so we can feed the newborn. Okay, so you actually need both of those hormones if you choose to breastfeed. And that goes for like breast pumping as well. All right, so now let's chat about a couple of notable changes that happen to the mother during pregnancy. This is by no means a comprehensive list. We're just going to hit some highlights. So if you are interested in this topic, don't hesitate to investigate a little bit more in your textbook or online, any kind of reputable source. So again, we're just going to hit some highlights. The uterus, first of all, pre-pregnancy. Okay, so before we make the baby, the uterus is only about the size of a fist. But by the end of pregnancy, the uterus stretches from the pelvic area all the way up to the xiphoid process of the sternum. And just in case you have forgotten where the sternum is, it's your chest bone, right? So we're going all the way from the pelvis all the way up to your chest bone. Okay, so the uterus, it gets big. Okay, now obviously it has to get bigger to accommodate the growing fetus, but don't forget there's other things involved as well. So the uterus also has to be able to contain the appropriate amount of amniotic fluid. It also has to be able to contain the growing placenta, and the myometrium, the muscle layer of the uterus, also grows because we're going to need all the help we can get to push the baby out during labor. So yes, the uterus has to get bigger because of the fetus, but there's a couple extra things in there as well that sometimes get forgotten about when we talk about uterine growth. We did mention mammary glands getting bigger. So just a reminder, they do get bigger. They start to enlarge during the first trimester. We mentioned that breast tenderness or soreness was one of the classic symptoms of the first trimester. The enlargement comes because of the alveoli within the mammary tissue. The alveoli are where milk is actually produced. We're going to need to make more of those so we have adequate milk production. We have to make sure we feed the baby enough so it continues to grow and develop outside of the body. We did mention that the mother's blood volume was going to increase due to the aldosterone secretion, but don't forget that that also means that cardiac output would increase. It could also cause a rise in blood pressure. Okay, and an increasing blood pressure as well. Hopefully not too terribly much for blood pressure increase, but you are likely to experience a little bit of blood pressure increase with the increasing blood volume. Now, even though we have more blood floating around in the mother's vascular system, venous return, especially from the lower limbs, may be hindered because as the uterus grows, it can kind of push or press on, like have increased pressure on those lower veins around the pelvic area, which would again hinder the venous return back up to the heart. So that means more of the blood would kind of pool in the lower legs, leading to varicose veins. And this could be one of the things that contributes to edema if the varicose veins get really bad. All right, a couple of more notable changes. To adequately supply the mother and fetus with the nutrition that it needs, pregnant mothers only need about 300 extra calories per day. Okay, so the idea of eating whatever you want, whenever you want, however much you want, it's not super scientific. We're not judging anybody, but it's not super scientific. We really only need about 300 extra calories per day. Now, some pregnant women experience food cravings. Some experience food aversions during pregnancy. Some experience both. Okay. Sometimes these go away after the baby gets here. Sometimes they don't. Okay. Again, every person's just different. The morning sickness that we've mentioned a couple of times, the nausea and or vomiting that many women experience, this is actually thought to be related to the elevated levels of HCG, estrogen and progesterone, that occur during that first trimester. If you remember back to our discussion on HCG, we said that the levels start to decline around the 4th month, which is coincidentally the beginning of the 2nd trimester, which again, coincidentally is usually around the time that morning sickness subsides. So we do think that there is a link there. Now, unfortunately, some women experience hyperemesis gravidarum, which is extreme morning sickness. A lot of people haven't heard of this or don't really know or understand what it is. And they just think, oh, you just get sick or whatever, just, vomit a couple of times. It's really no big deal. But this is actually like really extreme morning sickness to the point where the pregnant mother is experiencing dehydration, electrolyte imbalance, even possibly weight loss. And if you think about it, we don't really want to experience these things when we're not pregnant, but we definitely don't really want to experience them when we are pregnant. And so again, this extreme morning sickness, it is a little bit more extreme than what some people really think it is. And then last but not least, we've got progesterone causing the smooth muscles in the GI tract and the urinary system to relax. So if we have relaxed smooth muscles, peristalsis is going to slow down, which can lead to constipation and slow urine movement as well. So just some more uncomfortable symptoms. Now, pre-eclampsia. I think that this is becoming a little bit more well-known in society. At least I think a lot more people have heard the term, but they may not really know what it is. So approximately 2% of pregnant women will develop preeclampsia during the pregnancy. We don't really know what ultimately causes it, but we think it could be related to either insufficient blood flow to the uterus and or problems with the mother's immune system. But the classic symptoms are edema, like a little bit more of an extreme edema, increased hypertension, and again, like kind of getting into like the dangerous levels of hypertension, and then proteinuria, or protein in the urine, which, if you remember, you're not really supposed to have protein in your urine. So that means now we have some problems going on with your kidneys. Really, the only way to fix this is to actually deliver the baby. Hopefully, we are close to that full term mark, and the healthcare team does everything they can to get to that full term mark, but we do have to take the mother's health into consideration as well, because if preeclampsia goes either undiagnosed or untreated, it could develop into full-on eclampsia, which can lead to seizures, potentially fatal seizures for both the mother and the fetus. So this is actually like it can be deadly. So if you or someone you know is currently pregnant and starting to have some of these symptoms, I do hope that you take them seriously and make sure that you or your loved ones stay on top of it, and keep yourselves nice and healthy, and listen to your healthcare team, and make sure everybody's all happy and healthy. Okay. Now, we've worked really hard over the last 9 months of this recording to grow the fetus. It is time to give birth to the fetus. So childbirth, also known as parturition, we are going to expel the fetus from the uterus, either via the vaginal canal, but sometimes we have to do a little bit of surgery, a C-section, whatever we need to do to get the baby out. Most important thing is mommy and baby are healthy, right? So labor begins normally anywhere between 38 and 40 weeks of pregnancy. And we start the labor process by increasing secretions of prostaglandins and oxytocin, which are going to start the rhythmic uterine contractions associated with labor. This is a positive feedback loop. So once we start labor, we kind of got to keep on going. We're going to continue to release these hormones and these other chemicals until childbirth is over. Now, before labor begins, the cervix was blocked by what we call a mucus plug. This helps protect against infections that may be trying to come up through the vaginal canal. But once we start labor, now that mucus plug is just kind of in the way, so it falls out. And then if labor doesn't really progress after it starts, it just kind of stalls, it's not really going anywhere, then the healthcare team may decide to insert prostaglandin gels or start IV Pitocin, which is synthetic oxytocin, so we can make some progress and get those labor contractions going. So childbirth in and of itself is 3 different stages. Stage number 1 is dilation. This starts at the onset of labor and we go until we are fully dilated for the cervix, which is 10 centimeters. If you don't know how small 10 centimeters actually is, I would encourage you to get you a measuring device that does centimeters and look at how small 10 centimeters is and think about how big a baby head is. And just, yeah, it's the numbers, they don't go together, you guys, but it happens, right? Childbirth happens. Pregnant women, they make it happen by starting those contractions. Okay, so those contractions are actually going to start in the upper part of the uterus and move downwards because, as you know, we have to push the baby down and out. So that should make sense. At some point, the amniotic sac will rupture. Commonly, this is referred to as the water breaks. Okay, and then the fetus's head will move down into the pelvic area, and the whole baby will kind of rotate sideways because that makes it easier for the fetus to move through the pelvic outlet. And then we move into stage 2, actual birth process. So once we hit that full dilation stage, that 10 centimeters, this runs all the way until the delivery of the newborn itself. So we said that the head was coming, and then we're going to rotate. Everybody's moving to the side here, and it just makes it a little easier to come out. Now, this is also associated with stronger, more frequent contractions. This is also the stage where the mother starts to help push with her abdominal muscles as well. A common phrase is crowning. So you may have heard that term. That occurs when the fetus's head starts to stretch the vagina. So you can actually kind of start to see the baby's head coming out. An episiotomy may or may not be done. If it is, this is the surgical incision that's made to widen the vaginal orifice. This helps reduce tearing. Sometimes it's done, sometimes it's not. It's kind of between the patient and the healthcare providers. Now, once the newborn is fully delivered, we need to clamp the umbilical cord, and then we need to cut the umbilical cord. Now, normally babies come out head first. However, sometimes they come out tushy first. So buttocks first is known as a breech birth. Okay, there are additional complications that can come with that, but you got to do what you got to do. And then sometimes the vaginal canal is just not cutting it for various reasons, lots of reasons that a C-section might be done or cesarean section. But if the mother undergoes a C-section, the healthcare team surgically cuts through the abdominal and the uterine walls, and the fetus is removed that way instead. Now, once the baby's out, we still have the placenta to deliver, which is stage 3. I feel like a lot of times this is like an afterthought. Okay, the baby's out, everything's done. That's not really true. The placenta and the extra embryonic membranes, collectively, sometimes that's called the afterbirth, that also has to be expelled or removed from the uterus. One reason that the uterus will continue to contract to help expel that, this helps limit bleeding. But if we don't get it all out, this can either or lead to significant blood loss or possible infections that can get like really, really bad. So even though it's kind of overlooked, we don't really think about it a whole lot, it's actually a really important process. So we don't want to have this nice, healthy baby here and then mom gets sick because a little bit of the placenta or those membranes are left in by accident.